Discussing two late-break clinical studies, both under the name of Matrix. One is called Matrix Access, the second one is called Matrix Antithrombin. Both are focusing on a patient population which is characterized by having acute coronary syndrome, and we have basically any sort of ACS, meaning STEMI or non-STEMI, as well as unstable angina. For STEMI, I mean ST segment elevation myocardial infarction. Then if the patient has MI without that ECG feature, it's called non-STEMI, and then if he has just unstable symptom without troponin elevation, it's called unstable angina. First, we randomly allocated them to radial or transfemoral access site. These patients were ACS patients at medium to high risk who were supposed to be managed invasively, which means they were supposed to be brought to the cath lab and have a diagnostic angiogram done. If clinically indicated, they would also proceed to PCI. So to get an angiography done, you need to have an access site first. And the access site, actually, there are two choices right now. One is the femoral, which is the traditional one, the groin. The other one is the arm, the radial artery, which is more superficial, more technically demanded, but being more superficial, it's also associated to less bleeding complications, so hemostasis per se is much easier. There's been ongoing debate for probably for 30 years as to whether radial is better or not better than femoral artery. The reality is that the vast majority of interventional cardiologists are using the femoral artery because it's easier and because we were all taught to do that. So then the switching to a radial, you need to have very compelling evidence to do so, because indeed you are making your life much more complicated. And the evidence was not, I should say, clear-cut for the time being. Small studies or relatively small studies showing that radial could potentially be much better than femoral, but big studies, the big study that has been so far performed, which was called Arrival, was completely negative, was not showing anything. And so the community kept on debating whether radial was really something that was good for the patient or not really good for the patient. To get the 8,404 patients, so the study is really big. It's the biggest study ever performed on this matter. And we had two co-primary endpoints. One is called MACE, which is Major Adverse Cardiovascular Events. It's a combination of three items: death, MI, and stroke. The other one is NACE, Net Adverse Cardiovascular Events, which is the combination of MACE, as previously defined, plus major bleeding. For the MACE, so the pure ischemic endpoint, we were almost getting there in a way, in the sense that since we had two co-primary endpoints, the alpha level for significance was not the nominal 5%, it was 2.5. So the 5 had to be divided by the number of co-primary endpoints, so it ended up being 2.5. And the MACE rate were officially lower in the radial artery, but the p-value was 0.03, so officially we are not there. We missed the bar a little bit. But for the NACE, the superiority is amazing. It's a 2% absolute difference, and the p-value is very small, with the number needed to treat for benefit, which is in the range of 50-60, so quite low. Now, when you break down this composite endpoint to the component, the impressive findings that mortality was lower. Mortality per se was lower in the radial group, and also bleeding complications were lower. We also did a sort of exploratory analysis to understand what was the mechanism for the mortality benefit, and in our analysis we have identified bleeding per se, really actually the driver for this mortality benefit. Of course, if you just select or compare one axis versus the other, you are expecting access site bleeding complication to be lower, not non-access site bleeding complication, and that's what we saw. So that is very consistent.